You are most welcome to this talk. Now, today I want to walk you through something that has been appearing in national statistics offices across several countries, and it is something that I think deserves careful attention. We are going to be looking at excess mortality data, specifically focusing on what has been observed in younger age groups, typically those between 18 and 44 years of age. Now, what makes this particularly important from a data interpretation standpoint is that young adults historically have the lowest mortality rates in any population. So when we see deviations from expected patterns in this age group, even small percentage changes can represent something significant in terms of absolute numbers. But here is where we need to be very careful. If we interpret this data incorrectly, if we jump to conclusions without understanding the methodology, we will draw the wrong conclusions. So let me take you through what the data actually shows, what it does not show, and what questions remain genuinely unanswered. Before we go any further, let me be absolutely clear about what this video is and what it is not. This is an educational walkthrough of publicly available mortality statistics. I am not providing medical advice. I am not telling you what to do about your health. What I am doing is showing you how to read this type of data, what the limitations are, and how to think critically about statistical claims you might encounter. If you have health concerns, please speak with a qualified healthcare professional who knows your individual circumstances. What we are doing here is building data literacy, nothing more, nothing less. Now, let me show you the sources we will be drawing from today. The primary data comes from national statistics offices. In the United Kingdom, that is the Office for National Statistics. In the United States, we have the Centers for Disease Control and Prevention and their mortality surveillance systems. We also have EuroMOMO, which is the European Mortality Monitoring Project that aggregates data from participating countries across Europe. And we have some peer-reviewed literature that has attempted to quantify and characterize excess mortality patterns in recent years. Now, each of these sources has limitations, and I think it is important to acknowledge them up front. First, there is reporting lag. Mortality data, particularly when we want cause of death information, can take weeks or even months to be fully registered and processed. So the most recent figures are always provisional and subject to revision. Second, the method of calculating expected deaths, what we call the baseline, varies between organisations. Some use 5-year averages, some use statistical models that account for trends and seasonality. This means that the same raw death count could show as excess in one system and within expected range in another. We need to keep that in mind. So what do the numbers actually show? Let me walk you through this carefully. When we look at all age excess mortality, most countries saw significant peaks during the periods of acute coronavirus disease pandemic waves, particularly in early 2020 and again in early 2021 before widespread vaccination. That is well documented. But what has drawn attention more recently is that even after those acute peaks subsided, excess mortality in many countries did not simply return to baseline. It remained elevated above historical averages in various periods through 2022, 23 and into 2024, depending on the country and the time period examined. Now, here is the key point. When we stratify this data by age, something interesting emerges. The pattern of excess mortality is not uniform across age groups. In the oldest populations, those aged 85 and above, we tend to see patterns that largely follow expected epidemiological curves, peaks during winter respiratory seasons, peaks during heat waves and so forth. But in younger age groups, particularly those between 18 and 44, several analyses have suggested patterns that are less easily explained by traditional seasonal factors. Let me show you what this looks like in practice. If we take the Office for National Statistics data for England and Wales and we look at registered deaths by age group, we can compare actual deaths to the 5-year average. When excess is calculated as a percentage above expected, the oldest groups often show the highest absolute numbers but moderate percentages. The youngest adult groups, while having much lower absolute numbers because baseline mortality is low, have at times shown percentage deviations that warrant examination. Now, I want to be very careful here about absolute versus rate. This is something that often gets confused in public discussions. Let us say the expected number of deaths in a given week for the 25 to 34 age group in a particular country is 500. If the actual number is 550, that is a 10% excess, 50 additional deaths. Now in the over 85 group, expected might be 5,000, actual might be 5,200. That is only 4% excess, but it is 200 additional deaths in absolute terms. Both figures matter, but they tell us different things. The percentage tells us something about deviation from pattern. The absolute number tells us about population impact. We need both. What has been observed in some datasets, and I emphasize some because this is not uniform across all countries and all time periods, is that the percentage deviation in younger adult age groups has at times been proportionally larger than in older groups during certain periods outside of the main pandemic waves. Now, this is the kind of signal that epidemiologists and public health officials need to investigate. It does not tell us cause. Let me repeat that. It does not tell us cause. What it tells us is that there is a pattern that deviates from historical expectation and therefore warrants further investigation. Let me talk about methodology for a moment, because this is absolutely crucial to understanding what we can and cannot conclude from this data. First, the baseline calculation. How do we know what expected deaths should be? The most common approach is to take an average of previous years. But which years? If you include 2020 and 2021 in your baseline, you might artificially inflate expected deaths because those were unusual years. If you only use pre-pandemic years, you might not account for population changes, aging demographics, or other secular trends. EuroMOMO uses a statistical model called a Poisson regression that accounts for seasonality and trends. The Centers for Disease Control and Prevention uses different models for different purposes. The Office for National Statistics typically uses 5-year averages, but excludes the pandemic years for more recent calculations. Each method has trade-offs. Second, and this is critical, correlation is not causation. I cannot emphasize this enough. If we observe excess mortality in a particular age group during a particular time period, we cannot simply assume we know the cause. There are multiple potential contributing factors that would need to be disentangled through rigorous epidemiological analysis. Let me list some of the factors that have been discussed in the literature. Delayed healthcare presentations. During the pandemic, many people delayed seeking care for serious conditions. Cancer screenings were postponed. Cardiovascular symptoms were ignored because people were afraid to go to hospital or because services were overwhelmed. The effects of these delays may manifest as increased mortality months or years later, particularly from cancers diagnosed at later stages or cardiovascular events that might have been prevented with earlier intervention. Mental health impacts. There is documented evidence of increased rates of anxiety, depression, and other mental health conditions following the pandemic period. Some analyses have suggested increases in deaths from suicide and drug overdoses in certain populations, though this varies considerably by country and demographic group. Economic and social disruption, job losses, financial stress, housing instability, and social isolation are all known to be associated with adverse health outcomes. These effects may have differential impacts across age groups. Long-term effects of infection. Coronavirus disease itself is associated with increased risk of cardiovascular events, thrombotic events, and other complications for some period following acute infection. Several studies have documented elevated risks of heart attack and stroke in the weeks and months following infection. This is a plausible contributor to any observed excess, particularly in age groups with high infection rates. Changes in healthcare capacity and quality. Healthcare systems in many countries were under severe strain. Routine care was disrupted. Staff were exhausted and stretched thin. This may have affected quality of care in ways that are difficult to measure, but could contribute to outcomes. Now, here is what this does not prove. Observational mortality data of this type cannot definitively attribute excess deaths to any single cause. To do that, you would need detailed cause of death analysis, ideally with individual level data, linking outcomes to exposures, health histories, and other relevant factors. Some of this work is being done, but it takes time, and the results are often complex and nuanced, rather than providing simple answers. Let me talk about what we see when we look at cause of death data, because this adds another layer of information. In the United Kingdom, the Office for National Statistics publishes data on leading causes of death by age group. In recent periods, for the working age population, the leading causes have included heart disease, cancer, drug and alcohol related deaths, suicide, and coronavirus disease in periods when the virus was circulating widely. Interestingly, some analyses have shown increases in deaths from cardiac causes in younger age groups that exceed what would be expected from coronavirus disease alone. But again, interpretation is complicated. Cardiac deaths could reflect delayed presentations during the pandemic, effects of prior infection, changes in lifestyle factors like reduced physical activity and increased alcohol consumption, or other factors entirely. Now, let me tell you what we know and what we do not know, because I think this distinction is really important for anyone trying to understand this topic. What we know: first, excess mortality has been observed in many high-income countries in periods following the acute pandemic waves, not just during them. This is documented in multiple official data sources. Second, the pattern of excess mortality by age has not been uniform. Different age groups have shown different patterns at different times. Third, younger adults, while having low absolute mortality rates, have in some datasets shown proportional deviations from baseline that warrant investigation. What we do not know: first, we do not know the precise contribution of different factors to observed excess. Rigorous attribution analysis is ongoing but not yet complete for many countries. Second, we do not know whether the patterns observed will persist, diminish, or change over coming years. We are still in a period where the data is evolving. Third, we do not know with certainty why some countries show different patterns than others. International comparisons are complicated by different healthcare systems, different population demographics, different pandemic responses, and different data collection methods. What should we watch for going forward? I would suggest paying attention to cause of death breakdowns as more detailed data becomes available. Look for peer-reviewed studies that attempt attribution analysis with appropriate methodology. Be cautious about claims that attribute excess mortality definitively to any single cause without robust supporting evidence. And continue to monitor trends over time, because a pattern that looks concerning in one quarter might normalise the next, or conversely, a pattern that looks reassuring might develop into something more significant. Now, let me talk about the clinical picture in general terms, because I think this helps provide context. Young adults are not immune to serious health conditions. Cardiovascular disease, while more common in older populations, does occur in younger people. Conditions like hypertrophic cardiomyopathy, arrhythmias, and myocarditis can affect young adults and can be fatal. Cancer, while again more common with age, does occur in younger populations, and outcomes are heavily dependent on stage at diagnosis. Mental health conditions are a major cause of mortality in young adults, particularly through suicide, which is among the leading causes of death in the 15 to 34 age group in many countries. The question that the excess mortality data raises is not whether young adults can die from these causes, because clearly they can and always have, but whether the rate at which these deaths are occurring has changed compared to historical baselines, and if so, why. These are legitimate scientific questions that deserve rigorous investigation rather than premature conclusions. I also want to address something that I think is important for data literacy. You will find, if you look into this topic, that there are widely varying interpretations of the same underlying data. Some commentators emphasize the significance of any deviation from baseline and call for urgent investigation. Others point out that mortality data is inherently noisy, that year-to-year variation is normal, and that we should be cautious about over-interpreting what might be statistical fluctuation. Both perspectives have some validity, and the truth is probably somewhere in between. What we need is ongoing, rigorous, transparent analysis conducted by qualified epidemiologists with access to detailed data. And we need to be patient enough to wait for that analysis to be done properly, rather than jumping to conclusions based on preliminary or partial data. Let me also say something about how to engage with this topic constructively. If you are concerned about excess mortality trends, whether in young adults or in any population, the constructive response is to support calls for transparent data publication, rigorous independent analysis, and appropriate public health investigation. It is not constructive to make definitive claims about causation without evidence, to cherry-pick data that supports a predetermined conclusion, or to dismiss legitimate concerns without engagement. Science works best when we follow the evidence wherever it leads, acknowledge uncertainty where it exists, and remain open to revising our understanding as new data emerges. From a practical standpoint, what might an individual take from this information? Well, first I would encourage anyone to be proactive about their own health. If you have been putting off health screenings, if you have symptoms you have been ignoring, if you have risk factors you have not discussed with a doctor, this might be a prompt to address those things. Not because this data tells us something specific about your health, but because we know that early detection and intervention improve outcomes for many serious conditions. Second, I would encourage healthy lifestyle choices, things we know are associated with reduced risk of cardiovascular disease, cancer, and mental health conditions. Physical activity, healthy diet, moderate alcohol consumption, not smoking, maintaining social connections, seeking help for mental health concerns. These are all evidence-based approaches to protecting health. Third, if you have specific questions about your own risk factors or health status, please speak with a qualified healthcare professional who can provide personalized guidance based on your individual circumstances. Let me also acknowledge the elephant in the room. I know that some people want to connect this data to specific causes, whether that is coronavirus disease itself, vaccines, lockdown effects, or other factors. I am not going to do that in this video, and I will tell you why. The data we have looked at today does not allow us to make those attributions with any confidence. To make causal claims, we would need different types of studies, carefully designed epidemiological investigations with appropriate controls and individual level data. Those studies are being done, but the results are not yet fully available, and when they are, they will need to be peer-reviewed and replicated before we can draw firm conclusions. What I can tell you is that serious scientists and public health officials are aware of these patterns and are working to understand them. The process is slower than anyone would like, but rushing to conclusions would not serve anyone well. I want to come back to the fundamental point of this video, which is really about how we interpret health data. Mortality statistics are a valuable tool for understanding population health trends, but they have significant limitations. They tell us that something has happened, but they do not tell us why. They can show us patterns, but patterns can have multiple explanations. They can raise questions, but they do not provide answers on their own. What they should do is inform the direction of further investigation. When we see signals in the data, whether in young adults or any other population, the appropriate response is to investigate further with appropriate methods, not to jump to conclusions that the data does not support. One more methodological point that I think is worth making. When we talk about excess deaths in young adults, we are talking about relatively small numbers in absolute terms, even if the percentage deviation is notable. This means that the data is more susceptible to statistical noise and year-to-year variation. A few dozen additional deaths in a weekly count can swing the percentage considerably. This does not mean the signal should be ignored, but it does mean we need to look at sustained trends over time rather than isolated data points. We need to aggregate data over meaningful time periods and look for consistent patterns before drawing conclusions. The bottom line, if I can summarize what we have covered today, is this. There have been observations in mortality data from several countries suggesting that excess deaths in younger adult age groups have at times exceeded historical baselines in periods following the acute pandemic. These observations warrant attention and investigation. However, the data does not allow us to determine causes with confidence. Multiple factors could be contributing, including delayed healthcare, long-term effects of infection, mental health impacts, economic disruption, and others. Rigorous epidemiological research is ongoing and will be necessary to disentangle these factors. In the meantime, the appropriate stance is one of engaged uncertainty, taking the data seriously while acknowledging the limits of what it can tell us. I hope this has been useful in terms of helping you understand how to read and interpret this type of data. Remember that statistics are a tool, not an answer. They can guide us toward questions worth asking, but they rarely provide definitive answers on their own. That requires more detailed investigation, and that work continues. This video is for educational and informational purposes only. It is not medical advice. If you have symptoms or concerns, please consult a qualified healthcare professional. We use publicly available data and reputable sources, and interpretations may evolve as new evidence emerges. Now, before I close, I want to add a few thoughts on how this data is communicated and consumed in the public sphere. We live in an information environment where complex statistical topics are often simplified to the point of distortion. Headlines tend to emphasize either alarm or reassurance, rarely nuance. Social media amplifies the most extreme interpretations. And many people, understandably, lack the statistical background to critically evaluate the claims they encounter. My hope with this video is to provide a framework for thinking about these issues more carefully. When you encounter claims about excess mortality, here are some questions worth asking. What is the source of the data? Is it from an official statistics office or a peer-reviewed study? Or is it a secondary interpretation? What baseline methodology is being used? How are expected deaths being calculated? What time period is being examined? Is it a sustained trend or an isolated spike? What age groups are being discussed? Are absolute numbers and percentage both being provided? What alternative explanations are being considered? Is uncertainty being acknowledged? These questions will not give you definitive answers, but they will help you evaluate the quality and reliability of the claims being made. And ultimately, that is what data literacy is about, not becoming an expert in epidemiology, but developing the tools to think critically about statistical claims and to recognize the difference between what data shows and what people claim it shows. Thank you very much for watching. I want to tell you about something that happened last week, something that nobody in Brussels wants to talk about.